Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcasts, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adebuya. Today I'm joined by Deedra Geniesse. Deedra Geniesse is the Director of Clinical Nutrition Services at Stanford Health Care. With over 2 decades of experience as a registered dietitian, she brings extensive experience in both food service management and clinical nutrition. Holding a bachelor degree in dietetics and nutrition from the University of Central Missouri and a master's degree from the University of Kansas Medical Center. With 21 years in leadership roles, her approach emphasizes team empowerment, strategic growth, and innovation in clinical nutrition. Thank you for chatting with me today on the podcast.
Thank you so much for inviting me. I'm honored to be able to be here today.
With over 2 decades of experience in clinical nutrition and leadership, you have witnessed the evolution of the role of dietitians within it. Looking back, what are some of the most significant changes that you've seen in the field, and how have these shifts shaped your approach to leading a clinical nutrition team today?
In our profession, there have been some monumental things that have transpired that have changed the trajectory of our profession. Back in 1974, a physician wrote an article called "The Skeleton in the Closet." It was published in Nutrition Today, and it is an article that was written to highlight malnutrition and the prevalence of that in healthcare. In more recent years, the implementation of the nutrition care process is the framework for our critical thinking and decision-making as dietitians. The other piece that is critical to our work today is the nutrition-focused physical exam, which allows us to evaluate nutrition status and look for signs and symptoms of deficiencies or excesses and more accurately diagnose malnutrition. Recently, at the top of 2024, our profession instituted a requirement for registered dietitians to have a master's degree before they sit for their registration exam.
That's really fascinating, especially how a single article helped shift the trajectory of the entire profession. It's clear that the field of clinical nutrition has evolved significantly, not just in practice, but also in the qualifications and training required for dietitians today. Can you elaborate on the distinctions between registered dietitian nutritionists and other medical professionals that are connected to this field? How do their roles and qualifications differ, and how do they collaborate in a clinical setting?
Our credentials are RD or RDN, which stands for Registered Dietitian or Registered Dietitian Nutritionist. To become a registered dietitian, you must hold a master's degree. Before you can sit for your registration exam, you have needed to complete 1,000 hours or more of dietetic internship supervised practice, sit for your registration exam, possibly licensure if you live and work in a state that has licensure. Following the completion of your registration exam, you must also complete 75 hours of continuing education every 5 years and submit that through your professional portfolio. In addition to that, many registered dietitians also have board certifications in specialty areas such as oncology or renal or pediatrics and gerontology. Registered dietitians can be nutritionists, but not all nutritionists can be called registered dietitians. Anyone can call themselves a nutritionist. Someone can get a Groupon certification for $40 that says, "I'm a nutritionist." This is one of the platforms that many dietitians are very passionate about because we want to make sure that consumers and patients and people that need credible evidence-based nutrition information are getting that from relevant sources. And it's much more difficult in this day and age because of the accessibility of information at people's fingertips. And you can get information from an influencer, but what is their credibility and what is their level of expertise to be sharing that information with you? But registered dietitians are the only ones that now have potentially 6 years of education, as well as 1,000 hours plus of supervised practice.
Thank you so much for breaking that down. I appreciate that clarity because initially I thought that terms dietitian and nutritionist were being used interchangeably, but as you explained, that's not the case. Something else that stood out in your response is the gap in public knowledge about best practices in nutrition and diet, and how that space is often filled by individuals who may not have the proper qualifications, and how there is a risk of misinformation when those without the right expertise take the lead in shaping public understanding. At the same time, it's encouraging to hear that your profession is raising the bar by increasing the rigor of education and training. However, this new master's degree requirement does bring concerns about accessibility. Do you think this added educational barrier might deter professionals from pursuing registration? And what impact could that have on the field?
It's a bit of a mixed bag right now surrounding some of those changes in our requirements. I believe that we need standards to maintain the integrity of this profession and to keep it grounded in science. What that does to us long term in the number of dietitians that are choosing to enter into this profession. It's predominantly a profession that doesn't have a lot of diversity in it. When you change the requirement for how to become a dietitian, we've created more barriers for some people to be able to access this profession. And that's not going to serve us well in the future. There are organizations that have been created just for that purpose. One of them is called Diversified Dietetics, and they're looking at how they create access for people that do want to access this as a profession that have additional barriers to overcome.
It's encouraging to hear that there's a focus on the long-term implications of the profession, especially when it comes to the expanding pipeline of diverse, highly competent professionals. Building on that, I'd like to talk about the role of nutritional management. Recent studies have reinforced just how critical it is for improving outcomes in critically ill patients. Could you share some best practices for assessing and addressing malnutrition risks in this population?
The management of nutrition is important for all patients, but it becomes even more heightened with patients that are critically ill. We have a team of dietitians that are involved in all of the ICUs. We're heavily involved in the teaching of our residents, medical students, nurses, and training and retraining on malnutrition risks and what those look like, and when it's appropriate to consult with the RD. Our team has completed a lot of QI projects that aim at improving the care of ICU patients with strategies like volume-based tube feeding, our high-risk enteral nutrition guidelines for feeding critically ill patients that are in circulatory shock and on vasoactive therapies. One of the biggest projects that we have done and that impacts how we address malnutrition is that our dietitian individualization of enteral nutrition policy. This is a policy that puts the dietitian at the forefront of managing the enteral feeding process. It allows for the dietitian to intervene early, to modify, to discontinue or start components of that enteral feeding process. That has been very critical for the management of malnutrition, especially in those critically ill patients. We also are very present at rounds in the ICUs. Our dietitians are skilled at listening for nuances of things that might impact nutrition, and they're listening for ways that they can impact the care of their critically ill patients. We want to make sure that our dietitians are being bold in their interventions and in their recommendations so that they're being mindful of what those limitations are in ICU, but also being bold in applying the research and the evidence that we know exists for early intervention for nutrition support for these patients in the ICU setting.
One of the key takeaways from what you just described is the importance of collaboration between clinical nutrition teams and other departments, all with the patient at the center. I'd love to shift gears slightly and look at some of the common misconceptions in this space. You've already touched on one myth, but let's do some myth busting. What are some other common myths around malnutrition or nutrition in the hospital setting that you think are important to address?
Some of the other myths we face routinely is that if a patient is having diarrhea, it's caused by the tube feeding. There will be stops and starts on a tube feeding because of GI issues. One of our dietitians has a button that says it's not the tube feedings. And that's our longstanding joke as dietitians, is that the tube feedings are not what's causing the problem. Some of the other myths about TPN causing infection, and that we shouldn't start a patient on TPN because it increases their risk of infection. There have been many studies that have shown that is not the case. The ASPEN guidelines, the American Society of Parenteral and Enteral Nutrition, put that out in 2021 that states TPN does not cause an increased rate of infection for patients. The other myth that dietitians endure is that we're the food police and that we don't eat dessert. All we eat is salads, and that we go in just to talk to a patient about their likes and dislikes. Historically, one of the other myths we've broken out of a little bit is that a low albumin lab means you have poor nutritional status.
Thank you for sharing those. It's fascinating how some of these myths persist despite research and guidelines that prove otherwise. And also, just the realization that how to counter these misconceptions is really about empowering dietitians to take a more active role in patient care discussions and decision making. As a leader in this space, how do you empower your team and other dietitians to step into that role? And are there any specific initiatives that you have implemented to support this?
Making sure that our team is active in patient care discussions and decision making. We accomplish that first by making sure that we have adequate staffing and the representation for all of the service lines and areas that we need to have RD coverage. In our department, we nurture a culture of empowerment, confidence, and support. We encourage our team to stand firm in the science and the evidence of why they're making those recommendations, even when they do have to push back on a myth or a incorrect thought process that someone is sharing during rounds or in conversation guiding nutrition care. We want to make sure that we're training our dietitians so that they feel completely equipped and confident to be able to advocate for their patients and be able to express, this is the latest evidence and this is what our practice is here at Stanford. We have extremely strong mentorship within our department. It's not a formal program. We all are learning and listening from each other's experiences. And it's one of the most beautiful things about our team. The other thing that I would mention about our team in terms of how they come to the table for patient care discussions and decision making, all of our inpatient dietitians have been trained in SICP, which is the Serious Illness Care Program. And it helps train providers on those advanced care planning conversations. So whenever they're in a room and the conversation turns to a more serious note, they're already equipped to have that conversation.
What I'm hearing from you is that you've fostered a truly collaborative environment within your department, one that prioritizes mentorship and open communication and support. At the same time, you're equipping your team with the knowledge and the confidence to actively contribute to patient care discussions and really ensuring that dietitians have a strong voice in this critical conversation. This sounds like a really strong model. I'm curious, how does this compare to what is happening at other institutions? You might not have direct insight, but from your perspective, do you think this approach is unique? Or have you seen similar efforts in other organizations?
I would say that it's very unique. In my career, I have had the pleasure of working in multiple organizations with hundreds of dietitians, almost 25 years. The collaboration, teamwork, respect, trust that our team has within clinical nutrition as well as outside of the walls of clinical nutrition is not very common. I would say that in many organizations, I think dietitians are struggling to gain that trust, respect, and voice on the healthcare team. To our team's credit, they deliver day in and day out, and they've earned that respect and trust. They deliver such high quality of care and expertise that I don't find that across the country. I think it is uniquely Stanford. It's the most amazing group of people that I've ever had the pleasure of working with. And every day they bring me just pure joy to be involved with them, to be their leader, to advocate for them, to find ways to bring recognition and visibility to the work that they're doing is the most fun that I've had in my career.
You are quite passionate about raising the profile of clinical dietitians. How do you advocate for dietitians as essential members of the healthcare team? And what challenges have you faced in this process?
Some of the challenges that we face are when you compare the profession of dietetics and nutrition to other healthcare professionals, I think they're leaps and bounds ahead in terms of pathways for professional growth and development. There are things that I think should have been in place when I was first starting out as a dietitian, and we're still trying to figure out how to put that into place for our profession. We oftentimes look and compare the depth that nurses have for the pathways to go in their profession, and we just don't really have that for dietitians. We've been working really diligently in clinical nutrition to develop those pathways that we feel we need internally, as well as create pathways within our industry. We're working on creating RD specialist roles that bridge between level 4 and leadership. It gives people an opportunity to showcase and work in some of the skill sets that they are either passionate about or that they want to develop. Just on October 30th, we held our first inaugural clinical nutrition symposium. And we're fantastically excited about the completion of that. And we're already beginning our planning for year 2 to keep pace with the other disciplines that have really had a much stronger foundation of pathways and ways for dietitians to advance. Those are some of the challenges of advocacy for our team. Sometimes it feels discouraging because you feel like it's 20 or 30 years behind. But like I mentioned earlier, especially this team at Stanford, I'll never stop advocating and fighting for them.
First of all, it sounds like your team has an incredible leader at the helm, driving advocacy and meaningful change. So kudos to you for the work that you're doing in this space. I appreciate the challenges that come with creating growth opportunities, but on the flip side, it also speaks to the dedication of professionals in this field, a testament to how dynamic and evolving this work continues to be. Shifting gears a bit, I'd love to revisit an important aspect of patient care, which is caregiver involvement. In outpatient settings, caregivers play such a crucial role in nutritional care. How do you recommend involving caregivers, particularly when patients have specific feeding challenges?
One of the things that has to lead caregiver involvement is listening to what the patient and the caregiver goals are, getting the caregiver involved in those appointments and educations, and making sure that when meeting with the patient and caregiver that we encourage and foster transparency about real life and what their current and actual state. We can't help get you to where you need to be if we don't know where you're at now. There's no shame, there's no guilt, no judgment. Just tell us where you're at so that we can help get you to where you need to go. Once we bring the caregiver, the RD, and the patient to the table, we assess their readiness. What's their readiness for change? What are the barriers that they are facing in terms of making those changes? Do they have socioeconomic challenges? Do they have food access issues? Do they have feeding challenges, swallowing difficulties, other barriers that might impact their ability to meet goals? And the RD will sit down and listen to the patient and the caregiver. It's a very individualized plan of nutrition that's based off of their diagnosis and all of that information that they've collected and gathered. creating an individualized plan that helps, again, get the patient where they need to go. Then at the end of all of that, assessing their understanding of this plan and what's the projected capability that they have to be able to meet those goals. And it's that monitoring and evaluation feedback loop and revisiting those topics and goals. We don't do it individually. It's not the RD's plan. It's the patient's plan and the caregiver's plan and their readiness to make those changes at the time that it's needed.
This really highlights the importance of co-creating a nutritional plan, bringing together the patient, the caregiver, and the registered dietitian to develop something that is both effective and personalized. I imagine that the same approach applies when considering cultural and personal dietary restrictions. It's about having a conversation, understanding individual needs, and finding solutions that align with both health goals and personal preferences. How do you navigate those cultural and personal dietary restrictions while ensuring patients receive the nutrition they need?
In theory, it can sound difficult, but in actuality, it's not difficult for us as dietitians because the patient is coming first. When they're sharing with us, these are my cultural or religious or ethnic preferences, or even my personal preferences, we are doing our best to help them achieve their goal. While dietitians are not experts in every culture or ethnicity, it's all about the listening and hearing from the patient directly what their need is. That's another great thing about dietitians and our team at Stanford is they're extremely resourceful. If a patient comes to them and says, this is my cultural or religious preference, and I don't have any knowledge of that, they're immediately going back and figuring out, okay, how do I know what I need to know to help take care of this patient? If they're in the inpatient setting, it's a lot of times collaboration with our food services team and hospitality and the patient meal service. They're very resourceful, so they'll do whatever they can to help meet a need for a patient, but always want to be able to honor those preferences. It's part of their whole being, so we want to be able to honor that.
That's such an important point, and really those core principles apply across all healthcare professions. Active listening and truly understanding the patient's needs are essential. Whether you're an RDN, a nurse, a physician, or an APP, it's really what allows providers to deliver the most appropriate and effective care. As we wrap up our conversation, we've explored where the field has been and some of the current challenges. Looking ahead, I'd love to hear about any innovations in clinical nutrition that you're particularly excited about, whether in policy, guidelines, patient care, or operations.
There are a number of things that are pretty interesting and exciting. The telehealth platform has certainly been very exciting and caused us to shift a lot of our plans back in 2020 when we didn't really know how portable we were as dietitians. So that's been impactful. We're talking a lot in our team right now about AI and how we leverage that technology into optimizing the work that we do and being able to save time so that we can still spend it where it matters most with our high-risk patients. In our industry as a whole, in the state of California, we don't have licensure, but many of the states do. We're required to have a license in each state that you practice. And the licensure compact allows people to practice in more than one state and not have to hold a license in all of those states because we hold a national registration exam. Having to carry all of these multiple licenses, especially with neighboring states, is a burden. But Nebraska was the first state to pass the licensure compact, which is so impactful for dietitians, especially for those that might be part of a military family where they move a lot. Nebraska passed a licensure compact as well as Tennessee and Alabama. It's pending in Ohio. I'm fascinated to see how that plays out for our profession because it impacts our portability and the way that we deliver care to our patients.
Do you think California might eventually move towards a licensure system as well?
I would love to see the state of California have licensure. There's only about 3 or 4 states that do not have licensure. I am of the mindset that it's another layer of integrity that we maintain in the profession, making sure that you are who you say you are, you're able to provide the nutrition care that you're able to provide. And it just is another layer of integrity for the profession. In states that do not have licensure, there is a lot of lobbying that exists because people want to be able to say, I'm qualified to be able to provide you with this nutrition information. I think it's really important for the integrity of our profession.
The field of clinical nutrition continues to evolve with so many opportunities for growth and progress. It's also clear that advocacy for evidence-based standards plays a crucial role in shaping the profession's future, and it's inspiring to hear about the work that you and others are doing to uphold its integrity. This has been a wonderful conversation. Thank you for sharing your perspectives and your passion for advancing clinical nutrition. I truly appreciate your time. This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.